introduction and for the invitation. I think by now our listeners know a lot about the medication, the algorithm, and the guidelines with those excellent presentations we heard from the morning. So what I would like to do is a little bit deeper dive, not too deep because of the time limits, in the use of anti-resorptive, how did they start, and the evidence, and their position in the different algorithm and guidelines we have. So I'm going to touch base on the bone cycle and the anti-resorptive medication effect on the bone cycle, which is the mechanism of action of those agents, and how did they emerge, and what is the evidence for the different anti-resorptive medications, which are really the center of treatment for osteoporosis till now. Comparative efficacy, can we compare the efficacy of those agents, and then it's their role or position within the algorithm of different guidelines. And finally, just a quick touch on some concern in the therapy, using those agents and duration of therapy, and then summarize. So, of course, bone is a living tissue that it gets renovated, though slowly, and the way it's renovated, as it shows here, is by making small pits or holes by certain cells called osteoclasts, and then after doing so, this process stops to be reversed with other type of cells called osteoblasts that can first make a new bone called osteoid, and then it mineralizes the bone, leading to a full filling of the gap that's made by the osteoclast. And this balance is what make our bone vital, and at the same time keep the bone in balanced way so we don't lose bone. What happened, because either of aging or when estrogen stops in a woman after menopause, that the balance will be different, where there is a little bit more digging from the osteoclast, and those holes or pits are not filled completely by the osteoblast. So that causes a little bit of negative balance, and over time that will be causing the thinning and deterioration of the bone quality and what we call osteoporosis. So when we talk about anti-resorptive medication, we talk about medication that stops the first step, which is the resorption of the bone, as we see it, which is the action of the osteoclast, which is breaking the bone in small holes or pits that should be filled later on by the bone-forming cells or the osteoblast. So the different anti-resorptive medications we have are mostly bisphosphonate, which is the bigger or larger group, and the earlier one in introduction for the treatment of osteoporosis. We have also the SERMs, which are estrogen-like agent, or selective estrogen receptor modulators, which is basically the raloxifene. And then we have the rank ligand inhibitors, or denosumab. And we did for a while, however, this was stopped, which is the cathepsin inhibitors medication, odankatib, which unfortunately was stopped after its development. So starting with bisphosphonate, as you see on the upper picture, bisphosphonate get a very good adherence to the matrix of the bone, to the mineral of the bone, and then it gets released, and by releasing it can poison the osteoclast, causing apoptosis or death of the cell, and it stops it from functioning. Therefore, as you see in the last picture on the right side, that the osteoclast is not able to dig that pit in the bone. So this is basically how it works. And because it adheres to the bone, it can be released slowly. Its effect can stay for a long time, even after you're stopping the medication, which is a point that we will discuss later on. Now, in the picture on the low side, this is where this newer medication, the cathepsin inhibitors, was developed to stop a certain enzyme, which is important in digging this pit by the osteoclast. Unfortunately, this medication was stopped. It was very promising because normally when you stop osteoclast or resorption of the bone, you also slow bone formation. So both of them will slow down. This is a negative, actually, point of anti-resorptive medication. But with the cathepsin inhibitors, was supposed not to slow the bone formation, only to slow bone resorption. Anyway, this drug might come back later on, so I thought I would just mention it. Okay, how does this process goes on? The osteoclasts actually are the one that start the whole process by producing certain proteins called rank ligand. The rank is receptor on the osteoclast. Those are the digging or the resorption cells. And to activate those cells to an active osteoclast, you need to stimulate that receptor, which is the rank receptor. And this is done by a protein by the osteoblast called rank ligand. There's another protein called OPG that block this effect. And indeed, denosumab, which is another important anti-resorptive medication, is nothing but antibody to the rank receptor, to the rank ligand. So it actually blocks it from working on the rank receptor. And this way, it will stop the cells from differentiating into active osteoclast. Now, you saw this slide before from Dr. Riyad Suleimani, and it tells you about the effect of estrogen. So SERM, our selective estrogen receptor or estrogen analog, raloxifene, which works exactly like estrogen on the bone by also improving the osteoblast and osteocyte function, but by suppressing osteoclast effect, and therefore it will prevent also bone resorption. So going back to the bisphosphonate, this is the largest group of anti-resorptive medication. And as you see here, they are very much analog to a component called pyrophosphate. And therefore, whether it's an alendronate or residronate or zoledronic acid, which are the different bisphosphonates we have, they can always attach to the bone and cause decrease in the resorption of the bone by suppressing the osteoclast. Now, those are the one we have practically. We have alendronate. This was the first introduced in 1995 and was really the beginning, what I call, of the osteoporosis revolution, if you want, where interest in osteoporosis start to occur. Now, residronate is another oral bisphosphonate, and zoledronic acid is the IV intravenous bisphosphonate that is introduced once yearly for patients to treat or manage osteoporosis. Ibandronate is another bisphosphonate that is not commonly used here in our community, but it works well for vertebral fracture. As you see, all bisphosphonates have good evidence for preventing vertebral fracture, but for ibandronate, it does not have the evidence to decrease hip fracture. So it's a little bit weaker type of bisphosphonate, whereas the others have this evidence. Now, if we go to those agents one by one, alendronate was the first to come. There are a lot of studies. It came in 1995, so you can imagine we have a huge amount of experience with this agent, and this is one reason why we always put it as a first-line agent, oral bisphosphonate. Now, this is the original study showing oral alendronate in 3-year study, improving lumbar spine by BMD by almost 8%, and the femur neck by about 4 to 5%. Now, of course, there were also fracture data, and the data showed that it decreased vertebral fractures by almost 50%. For non-vertebral fracture, the decrease was less, in the range of about 30% or so. Now, because of the time accumulation of experience with alendronate, there were many other analyses for its effect 10 years later. This one is a Cochrane database analysis done in 2008, so almost 13 years later, showing that alendronate was quite effective in decreasing vertebral fracture. And here, looking in secondary prevention, meaning subject who have already fractures, and it shows about almost 60% reduction in vertebral fractures in those who have already established osteoporosis. Similarly, for hip, there was about 50% or so decrease in hip fracture in those who already have established fracture before. Now, one thing we learned also from study on alendronate, which is important, is the issue of the duration that we will talk about later. But as you see in this study called FLEX, where they treated patients with alendronate for 5 years, and then they switched them to placebo for another 5 years, versus another group that continued on alendronate for 10 years. And you see that for hip and non-vertebral fracture, there was no difference between the two groups in terms of fracture rate, whereas in the vertebral, especially clinical vertebral, those who continued on alendronate did better. So this is where the idea of discontinuation of bisphosphonate came in, because the effect of the treatment can last for a few years after stopping the medication. Now, another very important agent is zoledronic acid, and the Horizon study was published in 2007 showing that actually zoledronic acid is a very, very strong bisphosphonate in suppressing bone resorption, can decrease hip fracture, can decrease also vertebral fracture almost by 77%, 40% decrease in hip fracture, and 25% in non-vertebral fracture. Now, again, when we have extended study for another 3 years, then also the same phenomena was seen where non-vertebral fractures were not different in the group that stopped zoledronic and took placebo for 3 years. Again, the effect can last beyond stopping the medication, although if you look in the vertebral fracture, there was still benefit from continuing the medications. One thing we learned from zoledronic acid is decreased mortality. So those agents, bisphosphonate, especially IV bisphosphonate, show that we can improve survival and decrease mortality in patients who were treated with this agent, especially after hip fracture. Now, for raloxifene, this is an estrogen-like agent. However, it does not have bad effect on the breast. Actually, it decreased breast cancer. The evidence for it in the Moore study was only in decreasing vertebral fracture and did not show decrease in non-vertebral fracture. So its use is limited to decrease vertebral fracture, and actually it's limited for postmenopausal women in the age of 50 to 60 who does not have severe postmenopausal symptoms, because this agent can increase actually hot flashes, and they don't have history of cardiovascular disease. But it's really useful in those who have history of breast cancer or strong family history of breast cancer. So it's an alternative therapy. Now, another very, very important anti-resorptive medication, and it's really the strongest out of our armory of anti-resorptives is the denosumab, the anti-rank rank ligand antibody. So the evidence or the experience with it, the first study was a 3-year study, then was extended, and now we have almost 12 years or more of experience with this agent. Now, this agent is a little bit different from bisphosphonate in its action, but also in its effect on the BMD, where the BMD increase continue beyond the 3 years, and those who were treated for 8 or 10 years continue to increase their BMD across the duration of time. We don't see this with bisphosphonate usually. Now, more important is the fracture data, where it shows that, of course, with the 3 years study, there was significant decrease in the vertebral and the hip fracture, but this effect continued to be there during this study, as long as the subjects are on treatment, of course. So here the effect will not continue beyond the discontinuation, as we will show in a minute. So can we compare those agents? Comparing is difficult because most of those agents were not measured head-to-head, although there are some head-to-head studies. However, there are meta-analyses, including this latest one in 2019, that try to compare all the agents. So if we just focus on the anti-resorptive agents we have, for vertebral, we have very strong agents. All of them work very well. Denosumab has probably the best evidence, followed by zoledronic acid, followed by the oral bisphosphonate. Now, when it comes to the hip, the evidence is less. And although all those agents I mentioned do have evidence for hip, except, of course, ibandronate, the effect is very much similar in all those agents. They're not so much different in terms of efficacy. Now, I have to mention that those agents do not come without side effects. So with oral bisphosphonate, with all bisphosphonate and denosumab, because of its anti-resorptive effect, hypocalcemia can happen, especially in renal patients. So we have to be careful to be sure that our patients are not calcium or vitamin D depleted. We replace them before, and sometimes we have to check, especially with zoledronic acid and denosumab, because they are the strongest agent in terms of anti-resorption. For raloxifene, the estrogen receptor modulator, hot flashes, and even venous thromboembolism was reported, and rarely a cardiovascular event. Now, as you see here in the picture, this is what we call atypical fracture and osteonecrosis of the jaw. Those are rare events that happen with bisphosphonate and sometimes denosumab. However, they are extremely rare. Now, with osteonecrosis of the jaw, this is just necrosis that can happen in the jaw, especially for those who have dental issues that need to be cleared before using a strong anti-resorptive. Fortunately, it's extremely rare, and it shows mostly in patients who have cancer. So the evidence here, the occurrence is probably in the range of 1 to 100,000. However, a typical fracture could happen in the range of 1 to 1,000 or so, and it depends on the duration of the treatment, can be even higher. And those are special fractures that happen due to the sclerosis of the bone due to the long use of anti-resorptive therapy. However, those are rare, and the benefit of those agents way outweigh such a risk. Just to mention that there is this phenomena of withdrawal that was mentioned today with denosumab. So it's not like bisphosphonate where the effect can last longer and slowly come down. The withdrawal from denosumab can cause significant decrease in bone density and sometimes increase in fracture rate. So now it's part of all guidelines that when we stop denosumab for any reason, should be followed by anti-resorptive therapy like bisphosphonate, and sometimes a strong one like IV zoledronic acid. So finally, just to mention the location of those agents within the algorithm. This was discussed earlier by Dr. Al-Muhayya, but I'll just wrap it quickly. Of course, always, and this is, I just chose the ACE guideline because it's simpler. Of course, lifestyle, fall prevention, calcium, vitamin D should be in good position before any treatment. So if we made a decision for osteoporosis pharmacotherapy treatment, we have to ask about the renal function. Is GFR more than 30? If it's not, then bisphosphonate cannot be used in this group. And we might consider denosumab. However, we have to be careful with those renal patients, especially with renal osteodystrophy, and we might have to refer those patients to a specialist like endocrinologist. If the GFR is more than 30, then also we want to be sure that we have no contraindication for oral bisphosphonate, including esophageal stricture, varices, Barrett esophagus, achalasia, and recently many people with bariatric surgery, which may be a contraindication sometimes, especially if there's a high anastomosis, and also inability to follow dosing instruction. Then, of course, in this case, we would prefer IV bisphosphonate. But if there is none of those contraindication, then oral therapy, bisphosphonate, would be the drug of choice. Of course, alternatively, denosumab can also be used here. So, for patients with high risk, but not very high risk, those who do not have prior fracture as example, the alternative is oral bisphosphonate or IV bisphosphonate, denosumab or risedronate. And we start usually with oral. Alternatively, we use the IV. And if they are responding well, then 3 to 5 years of therapy is enough. 3 years of IV, 5 years of oral. But if they're not improving or if they develop any further fractures, then we go to a stronger anti-resorptive like IV zoledronic or denosumab, or even consider anabolic. I'm going to skip the next one because it's more of the very high risk that we will hear, I'm sure, from Dr. Shakir on it. So just a couple of words on other use of anti-resorptive. We should not forget its effect in glucocorticoid-induced osteoporosis. And here, bisphosphonate is a first-line therapy in most patients who are not childbearing, but there are alternatives, including, of course, IV bisphosphonate, teriparatide, and denosumab. But when we talk about women of childbearing potential, less than 40 or 45 years, then oral bisphosphonate is the drug of choice in those patients. Finally, there are some data actually on using agents, especially bisphosphonate, earlier in terms of prevention. I thought I'll mention just this study, which is a recent one in the New England Journal, where patients still with average age of 70, but if you look in their parameters, they have a BMD, they have a risk fracture by fracs of less than 20, so 12%, and hip is 2.3%, which is below the threshold in the US. Of course, we have different threshold here. And also, if you look in their BMD, is not osteoporotic. So those patients were treated with zoledronic acid for 4 subsequent years, and they showed significant decrease in fractures later on. So anyway, this is not to tell you to use it this way, but something for the future, I think, to think about. Let me summarize here. Anti-resorptive drugs such as bisphosphonate, denosumab remain first-line treatment options for osteoporosis. The ongoing need for bisphosphonate should be assessed after 5 years for oral and 3 years for IV, and treatment may be interrupted as discussed earlier today. Progressive bone loss will recur slowly in the case of bisphosphonate, but in case of denosumab, we should not interrupt therapy without switching to another therapy, usually anti-resorptive also. All patients will need ongoing monitoring, and most will require some long-term therapy once started. Raloxifene may be considered in women who do not tolerate the first-line anti-resorptive drugs. Thank you so much.